the moment, it's still quite left field for people to conceptualise in regards to spine anyway, functional injuries, which can be as painful and disabling as, you know, falling down the stairs and having a burst fracture. Okay, so I put them in that order specifically because in terms of helping people, the massive numbers of patients that I've seen over the years, this qualification here has probably had the least impact. Okay, most of the help, the thousands of patients that I've seen over the years with spine-related conditions have been aided by my understanding and practice and passion, I suppose, for weightlifting and athletic and functional fitness training and coaching. As physiotherapists, roughly what percentage of your patient load would be spine related?
70 or 80.
That's huge, isn't it? That's huge. So even in the musculoskeletal side of things, with all of the joints that we have, the back is most susceptible to injury. And if we look at work cover claims, we look at orthopedic surgery, it's always the lumbar spine. Okay, and you will put us out of business, honestly, and I don't care about that because I'm about to retire. Okay, but no, you seriously will put us out of business if every single physiotherapy studio and EP studio understood movement proficiency for the lumbar pelvic spine. We would be out of business. Also in the breaking news that there's an opioid crisis, and how can we possibly say there's an opioid crisis and not in the same breath also acknowledge that we have a rehabilitation crisis? Okay. Yeah, and in some regards, I find it really cruel that someone who is in pain is denied opioids in order to live their life, and as clinicians, we are not saying, hey, let's adopt an adjunctive approach to addressing the cause so that we can wean you off your endo. That it has to be a two-pronged attack. I think we have to control symptoms and do that however you want, with whatever lowest risk potency intervention you like, whether it's a hot water bottle or whether it's opioids. But if you do it in conjunction with eliminating their movement dysfunction, I can promise you they won't be on endone forever and they won't be using the hot water bottle forever. And I know that there's a lot of chronic pain patients that are terrified of this because they're actually finding it really difficult to get pain relief now. They're finding it that they're stigmatised, and the GPs are all, you're seeing this from the college, I'm sure, you know, you shouldn't be prescribing opioids.
I do what I think is right.
Yeah, that's right. But yeah, and if you can then direct them towards people like Russ, and who are actually, if it's back pain, that hey, let's pursue your quality movement. It's not about exercise either. I said to Kieran earlier, it's not an exercise program. Exercise is related to capacity and athleticism, whereas the cure for the disease is related to movement, skill and quality. And there's a huge difference between being fit and strong versus moving well. I'd rather you be the weakest person in the room moving well than the strongest person and fittest person in the room moving poorly, because the strongest, fittest person in the room moving poorly will eventually become the weak, painful person. Impairment ratings, my favourite thing to do on a Monday afternoon is go through that bloody DRG, the AMA 5, yeah. So this is crazy, right? Impairment ratings are based on a structural framework ignoring function. So if we have two individuals with identical severe pain and disability, one has had 12 months of physiotherapy, and one has had a lumbar fusion and 12 months of physiotherapy, the DRE rating is probably like 20% difference, okay? And that's even though the patients have the same level of pain and disability. Simply because of a structural intervention, the PI difference is triple, which then relates to compensation. Okay, so they are totally ignoring the aspects of function in awarding compensation. Why is function not important? Why is function? Of course it's important. It can't base a whole system around the structure of the spine.
But I guess my question is, how are we disseminating this information to your peers, your cohort, to try and get that more generic buy-in from that level?
It's interesting you say that, because I've sometimes thought about going back to uni to become a physiotherapist to get the buy-in. Because it's kind of, I sometimes think that the patient doesn't want to listen to me because they just think I'm a surgeon. What would I know about the musculoskeletal system? All I'm interested in is holding the scalpel. So yes, I take your point that you're a neurosurgeon, you must know what you're talking about. But in actual fact, most neurosurgeons are not talking about this.
Yeah.
But you've just got to be relentless. Like, why? Why are they not accepting this? Because it would mean a complete reconstruction of the university training.
Yeah.
It would mean a reconstruction of the textbooks. It would mean pain specialists and surgeons themselves. They would all, the whole industry is a $1 trillion industry. Like, think about that. Do we really, do the vested interests really want to cure back pain? Like, that's pretty spooky, right? And we already said at the beginning, it's the leading cause of disability on the planet.